and welcome to our program today. Very excited. We'll get started in just about a minute. In the meantime, as usual for our programs, please welcome to chat or comment. But if you have any, do we have a Q&A? I'm trying to see, and no, I don't see a Q&A. Maybe we don't have a Q&A here.
There's not a Q&A because this is a meeting instead of
Oh, I see. Thank you. Yeah, so you could put questions in the chat. So unlike our webinars, you can put questions in the chat here, please do. And actually we could open it up for conversation as well because it is a Q&A. It is a meeting, excuse me, rather than a webinar. I have a pretty full program, so I'm going to get started without further ado, and hopefully we'll have some more people join us as we do that. I'm just going to share my Microsoft PowerPoint. Actually, I'm just going to share my whole desktop so everyone will see everything, just because I have some slides that I want to, actually some data that I want to share as well, of course. Slideshow. Start. Sorry about that. Here we go. Hey, Janine. Thanks for joining. Well, again, welcome everyone, and thank you for joining today. For those who find this interesting and worthwhile and want to share, the recording will be up on our website by Monday. Some of the resources that I'll talk about today are already up on our website on our dedicated Hudson Valley page. If you go to our website on the right-hand side, it says New York, and then you click on that and you'll see Hudson Valley. Without further ado, I'm going to get started. I think most of you know who we are, but just in case, we are a nonprofit, nonpartisan organization dedicated to improving care and quality of life, principally for older adults who live in nursing homes and assisted living. We do and have since 1989 done mostly policy analysis and systems advocacy. Over the past 20 years or so, we've done more and more work with data, some of which we're going to hopefully share with you today in a way in which that is useful, for you. And then we do programs such as this and our monthly webinars that are geared to educating the community about what is going on in nursing homes. And last but certainly not least, we are the proud home of 2 local long-term care ombudsman programs in the Hudson Valley. And this program today, of course, is focused on the Hudson Valley. Lastly, our website is nursinghome411.org. Working with us is John Rodat, Public Signals LLC. John is just an extraordinarily smart and dedicated individual who has been working in New York State policy and health policy and on data for many, many years. And some of the visualizations that I'll show you today are courtesy of John and our working together over the last couple of years to make the data, as John notes here, use the damn data to make the data more useful. And I'll just note one reason why we do that. I remember that my predecessor, Cindy Rutter, said to me, and I think others at a meeting early on in my career, that, of course, we're doing this all for the residents, and we're all here for the residents, even if this is being heard by legislators or legislative aides, local organizations, certainly the families and the ombudsman and advocates who are joining us. We're here. We do because of the residents. But what the point that Cindy was making was in regards to the data is that it's important and valuable to have and to honor the stories of individual residents. But when it comes to changing policy and trying to improve the system so that it helps those residents better, having data is really important. And so that's why we focus on it here in our work and why we focus on it here in today's program. So I'm going to provide a data briefing and some insights, some tools that you could hopefully, I think, use to improve or to supplement and support your work in supporting resident care. And then I'm going to focus today, our residents' rights half of the program will be on discharge, nursing home discharge and transfer. And we'll leave some time for Q&A, I hope. So the first part is data insights and resources. So the first thing I'm going to show you is what's called the provider database. This is put out by CMS, the Federal Centers for Medicare and Medicaid Services. It's updated on a monthly basis, and it includes about 3 years of data. So it's a moving picture of what is and what has gone on in the nursing home world. And I show what's included here. It has the name of the facility, of course, who owns it. If it's owned by a what they call affiliated entity, would be if it's a chain ownership, and we do have some chains operating here in the Hudson Valley. Uh, whether its most recent inspection was more than 2 years ago, of course, that would be a red flag for us. Its ratings, some staffing information, and also whether the facility has been cited, and if it's been cited, excuse me, whether it's faced fines or other penalties. And those general data are available here. If you're looking for New York, or if you're looking for other states, this is where we post it. But what I've done as part of this project is to put together data sets that are just focused on the Hudson Valley. So this is just a snapshot, and hopefully this will work. I'm going to take you to, can you see that? Rachel, nod yes. Oh, good. Thank you. So this is the Hudson Valley provider data set. So essentially what I did is our normal data sets are searchable by state, by region, etc. What I did is I just drilled down to the 9 counties that we're talking about here and covering in our programs. So you can see here, you can look up by facility. I'll make that a little bit bigger. We include the CMS certification number because that's just a good reference point in case anyone ever needs it. But we include the provider name, their address, their city, town, zip, their telephone number, and et cetera. So a couple of important things here is, again, if you're looking at an individual facility, you can select it. Say I was looking for Briarcliff Manor. Obviously, it's right there. Or I could do a search. I could easily see, I'm showing here what all the facilities are. But also, if I was looking in a particular town or wanted to select a few towns, here you can see in the scroll down menu, it's select all, but I could select a few towns. I could say Fishkill, and then Highland and Holmes, and that would just bring up the the towns that I was interested in looking at. If I was helping somebody who is looking for facilities in the area, if I received a complaint, say I'm a legislative aide, if I received a complaint from a constituent about what's going on, just different ways, or ask for request for guidance from a constituent. Of course, for the long-term care ombudsman program, looking to see when making assignments, when looking at what facilities to go into, a way to kind of see what is going on in different areas and narrow that down. And then we could do the same thing with counties. We could select multiple counties or just look at one county. Then the other information here that I was talking about, the more substantive information, is ownership type. So I could look at the for-profits versus the not-for-profits. This information I just downloaded this a couple of days ago. So this is the number of certified beds in each facility, and then the number of residents that they actually have. It may not be current as of today, but this is what they were showing. Most recently reported, I should say, to CMS. Whether they're in a hospital, their legal business name, the affiliated entity, again, that is the ownership group or the chain affiliation, whether they're in a continuing care retirement community. We do have a few in our area that are part of a continuing care retirement facility. And then these next two get at some of the most poorly performing facilities, whether a special focus facility candidate or a special focus facility. Special focus facilities are among the facilities that are performing worst in the entire country, and they're selected for special oversight. So you can see, like for instance, this one is an SFF candidate that is number 25, and that's the Eleanor. So that just points it out. So there's SFF facilities, special focus facilities, and then their candidates. So what CMS is doing here is letting you know that these are facilities with especially severe and long-standing problems. Uh, CMS recently, and this is, well, I guess a few years ago now, and this is thanks, so let me just quickly, set just as an aside, I know that as advocates, as family members, as ombudsmen, that our work can often seem frustrating. So I wanted to point out here that this is something actually that CMS added in response to our advocacy, the Consumer Voices advocacy, and the Center for Medicare Advocacy's advocacy, is to include an abuse icon on Care Compare, on the Federal Nursing Home Care Compare website, if a facility has been cited for abuse. And so you can see here, no or yes. This doesn't mean if it says no, that there's not been any abuse. It's only when there's an indication of yes, but it's another way of looking and saying, okay, what is going on in the facilities in my area? For instance, I can, rather than having all of them, I can just click on yes, and I could see these are the 8 or so facilities that have been cited for abuse in our area. And that could be something else that is an alert for families, obviously an alert for long-term care ombudsman, et cetera. And I could just go back to the listing there. So I hope that I'm trying to go quickly because we have a lot to cover, but we could always in the future spend more time, or people have questions or would want a special program on how to use these drop-down menus because they come in pretty handy. So just again, I'm going to move fairly quickly. This I thought was particularly concerning. I didn't think so much in the past because it was pretty rare, but now we have, unfortunately, in New York and across the country, we've seen significant lapses in the extent to which the state departments of health are going into facilities. And that's really troubling. And I should add that one of the things that the nursing home industry has asked the Trump administration is to decrease the frequency of inspection. So this is something we really need to be aware of. But this again shows whether yes or no. So let's just say, we'll look at yes. These are all the facilities that have not been inspected within 2 years. That's an extraordinarily long period of time. So another way to think about, okay, what is going here? What is going here? Excuse me. What is going on in my facility? And one of them is, here's the Helen Hayes Hospital. I thought that might have been a different nursing home. But in any case, Helen Hayes is actually one of the better nursing homes, or one of the better staff nursing homes, I should say. So let me clear that out again. Just clear that. This is whether they've had new ownership in the last 12 months. This is whether they have a resident and or a family council. This is self-reported, so just to be careful, but it does give you some heads up, at least. And then here we have the overall rating, their health inspection rating, their quality measure rating, and their staffing rating. There's some other ratings in between. And then this is not my favorite place to go for staffing because the quarterly reported staffing I think are much better to use, but you do get an idea here from this, from what's reported here of their, again, what their reported nurse aide staffing is, reported LPN staffing is, reported RN staffing, and then their reported licensed staffing, which combines the LPN and the RN, and then their total nurse staffing. And then importantly in column AH here, you can see total number of nurse staff hours per resident per day on the weekend. So that's of course really important too. We have registered nurses on the weekend, reported physical therapist staffing. As I said, we have some better staffing data, but this is nice to have because it's included in the summary, included in the ownership information, which can be useful. This provider data set can be useful in a number of ways, especially if you're speaking to a state congressperson or their staff, or a state legislator, assembly member, or senator and their staff, or a local agency. So we have registered nurse turnover, total nursing staff turnover, which is important. A lot of facilities, for instance, well, the industry overall says, oh, we have a staffing crisis. We can't hire more staff. We're short staffed. We shouldn't be penalized for having short staff. But as you can see here, looking at the total nursing staff turnover or the registered nurse, turnover, it's enormous in some of these places. Look, this facility, number 9, has a 72.4% turnover rate. That is just incredible. Number 9 nursing home is owned by Centers Healthcare, and it is, it's the New Paltz Center for Rehabilitation and Nursing. And again, I know I'm providing a lot of information, etc., but there's a lot of ways in which you can look at this, and I would be happy, as I mentioned before, we could do, a special program talking about how do you look at a county or how do you look at a legislative district, etc., or tell me what's going on in my legislative district. We would be happy to do that, but just to provide you an overview and a tasting of all this information and how it could be potentially useful for your advocacy. And it doesn't have to be with a legislator. It could also be within the facility for a family council or for a resident council or for an ombudsman. Say, look, you have 71.4% turnover, or even here you have close to 30% RN turnover. What is going on in your facility? What are you doing to retain your staff? Because that's the big thing. That's what a lot of studies have shown. That's what we've been arguing for years. It's not that facilities can't find nurses to hire. It's that they can't keep them because their business model too often is set up in a way that nurses come in, nurse aides come in, and they quickly go out. Um, and then you'll see, I'm going to move on because we have other things to talk about, but these are the rating cycle. And I just want to mention quickly, I'm not going to go through all these data specifically, but there are, as I mentioned at the start, there are 3 years of data on a rolling basis in this provider data set. So rating cycle 1 would be the most recent year of the inspection. Rating cycle 2 would be the one before that, and rating cycle 3 would be the one before that. So this provides you with an ability to see the history of your facility and when it was last surveyed. Now, again, this is updated on a monthly basis, so it may take even a couple of months for the data to be cleaned up, reported to CMS from DOH, and then put up here. But you get a sense of when the facility was last surveyed and when the previous surveys were and what the results were of those surveys. So you can see here for each one, we include the total number of deficiencies, and then we break it up between the number of deficiencies that were from a standard inspection or survey and the number related to complaints. And I'll quickly say here, I know, and this has been something that has been an issue since well before I started 22 plus years ago, is that people feel like it's not useful to complain because too often the complaints are not substantiated by the Department of Health. However, and this is national data or national findings, there is much more likelihood to be a citation resulting from a complaint survey than there is from a standard survey. So again, we have the standard surveys are supposed to be the annual inspections, they call them surveys. And then in addition to that, the state Department of Health is required to respond to complaints. As I said, I recognize that it's very frustrating for families, and I've filed complaints a couple times myself over the years, and unfortunately not had great results. So I know that it's a frustrating experience. However, this just points to how actually it can be very valuable. And then lastly, before we move on, as I mentioned, we have the number of substantiated complaints here, the number of fines, and the number of penalties and payment denials and amounts of fines. So you can see, what's going on in your nursing home pretty easily. Like this nursing home number 9 has had, significant fines in dollars. So that I'm going to move on because there are a few other data sets I wanted to show you. So this is the nurse staffing data set. We just published this, I want to say like a week or so ago. And pardon me, I'm getting over a cold. So if I am not speaking clearly, just please shout out. So this is a snapshot of the nurse staffing data. So we have two files. One is of the nurse staffing in a nursing home, and the other one is of important non-nurse staffing. And first, I'll talk about the nurse staffing. So again, this is just a snapshot, and this file is now posted. The one I'm showing you now, the Excel file, is on the website, free to use and to download. And so we publish every quarter the staffing for every single nursing home in the country that is in compliance with federal reporting requirements. So it's not every nursing home, it's the vast majority of nursing homes. Some nursing homes either are out of compliance or quite often they've had their staffing data suppressed because of significant problems. So this is so if you don't see your facility, it's because there was some issue and they have not reported, or their data was not released, it was suppressed. So again, similar setup as the data set we just saw, except this is really just focused on staffing. So I have the name of the facility. I'll make it bigger so people can see. Better. There we go. Uh, so here's the name of the facility, city, county. So you can search by city, you can search by county if you wanted to see what is going on in your specific area, or multiple counties if you're looking, if you're a legislator and you are uh, serving multiple counties, or if you're an ombudsman and you are working in multiple counties. And then here we have the total nurse staffing. HPRD is hours per resident day. That's how people generally refer to staffing numbers, as the number of hours of staff time per resident in the building per day. And then what we started including here, this is the nursing home, this is just in the last two data reports, is there's a new methodology that was developed by researchers and was just published a few weeks ago in a scientific journal to help nursing homes and help the government and help the public understand the adequacy of the staffing. And how does it do that? So by adequacy, I mean the total expected nurse staffing. So it's based upon the census. The census is the number of residents in the facility. This is averaged out. That's why you see 108.66. It's the average for the most recent quarter, which is the last quarter of 2024. So it takes the census and then it takes the nursing case mix index. And the nursing case mix index is basically what the facility has identified as the needs of its residents. Every resident is assessed on, say, a quarterly basis or more frequently if their needs change, and based upon that assessment, putting them together for the facility has a case mix index. I'm really trying to streamline my discussion of it. So based upon, and so the case mix index really speaks to the needs of the residents, whether they're lower, whether they just need some basic services, or whether they have higher level needs. They might have dementia, or they may be bariatric, meaning that they are very overweight and they need more care and services, or they have respiratory issues, et cetera, which is a very high level of care and services. So that puts it all together, and essentially you're computing, okay, this is what the facility reported as the number of staff, this is what the facility reported as the number of residents that they have. This is what the facility has itself determined are the needs of the residents. Based upon that, we can figure out what the expected total nurse staffing is. And that's what this line is next to the colored line that you'll see on all of our staffing files now. So that's the expected total nurse staffing. So we have the actual reported, the total nurse staffing reported here, and then the expected nurse staffing. And you can see there's a difference. Looking at Andrus and Hudson, the total nurse staffing reported was 3.62, but based upon their case mix index, they should have had a staff of 4.93. And so the colored columns show the deviation from total expected. This facility Elizabeth Seton Children's Center has higher staffing, and it's actually meeting or exceeding its total expected hours per resident day. This facility, which is more of a white color, is very close. Glen Arden in Goshen is almost at its expected staffing. But as you can see, some of these that are more deeper pink are farther and farther from their total expected nurse staffing. And again, just to move things along, we do the same thing for RN staffing. So you have the total RN staff here, the expected based again on the facility's own assessment of its own residents, what that expected is, and then the deviation. And so you can look at the color coding. Again, you could select just specific counties and really get a picture, big or small or up to the facility level, what you want, what is going on in your area of interest. And then lastly, we have the same thing for the expected and actual nurse aide staffing. So I think really, really valuable information. This is brand new. Again, the article was just published in a scientific journal a couple weeks ago. Really excited about that because this is supposed to be, and the article actually is focused on providing a tool for nursing homes for them to better understand. Oops, I didn't mean to do that. Let me reshare my screen again. For them to determine themselves what are their staffing needs. But of course, we want people to use that information as consumer advocates and as researchers ourselves, people to have that information so that they can use it to identify what is going on in their facilities and the facilities in their communities. Lastly, we have the same thing for non-nurse staffing, and I think I'm going to skip that for now. Maybe we'll talk about that more next time, but I'll just quickly show you. We have the very same kind of setup here. This is non-nurse staffing, and we provide the hours and the hours per resident day, or sometimes it's actually, if you look at MPRD, minutes per resident day of administrator time, medical director time, hours of pharmacist time, uh, uh, excuse me, therapy staff, social work staff, etc. So you can see again what is going on in facilities in your area, feeding assistant, activities, etc. So those things are all really important. And what the data have shown, I should say, is that too often facilities, excuse me, are not providing a lot of staff in these areas, even though we know they have really important roles. And we actually were the first to investigate this, excuse me, and we did a study on the presence of medical directors in nursing homes. It was a national study. And what we found, and this continues to this day, is that about 40% of nursing homes don't report any medical director time whatsoever. And the medical director is responsible for overseeing the clinical care in the facility, making sure that the nurses are providing care that comports with professional standards, making sure that infection control protocols are being followed. So if you look at this in terms of the hours medical director, 0.66. So some of these places do have medical directors, but we have a lot of zeros here. I'll show you very quickly and then we'll move on. Just looking at 0. Look at how many facilities report 0 medical director time, 92 facilities. It's just in our area. So it's very, very alarming. Quickly, before we move on to the residents' rights portion, I wanted to show some of our data visualizations. This is what John Rodat has been helping us with. And it's a way of providing the information different ways of providing the information, I should say, that we think could be useful in different circumstances. So here, what we wanted to do is first show what is going on in the congressional districts. It's an election year. People are obviously very focused on what's going on in Congress on the national level, and certainly in the Hudson Valley, there's going to be some important elections. So here we show the nursing homes. Overall, we have 92 nursing homes, and it shows you where they are in terms of star rating. And then for each of the four Congress members, it shows where their facilities are. And darker means more. So you can see, looking at Mike Lawler, for instance, he has a total of 31 facilities in his district. 6 are 1 star, 5 are 2 star, 7 are 3 star, 3 are 4 star, 5 are 10 star. And you can go back to the data the provider data, and see very easily what those nursing homes are if you wanted to show him or Josh Raleigh's staff or George Latimer's staff, et cetera. We showed the same thing for staff ratings. This is just to give you some sampling of what we can do, and happy to help. Please do get in touch with us if you find that these data could be of interest. We're going to post this on the website, and you're free to use it and share it with your legislators. And if there's more, if you have questions, please let us know. This is again, just looking at the staffing star ratings of what is going on in the facilities. You can see, look at here, Patrick Ryan, the darkest spot, this is in the 1 star for staffing. That's very alarming. 8 of the 28 facilities in Patrick Ryan's region have 1 star in staffing. So what does that say? And of course, as I mentioned, just a moment ago, we can identify what those facilities are. This is looking at the number of facilities by congressional representative, again, that meets 4.1 hours per resident a day of nurse staffing time. That 4.1 HBRD, hours per resident a day, was identified many years ago as a minimum level needed just to meet residents' clinical needs. Doesn't include care with dignity. It doesn't include making sure people's call bells aren't going off for hours. It doesn't include having good infection control. It just includes the time needed to meet residents' basic clinical needs, 4.1 hours per resident day. It was a landmark federal study from 2001, and you could see which ones are, what percentage of nursing homes and numbers of nursing homes are meeting that for each of the congressional districts. And then 3.5 hours per resident day, that is the New York State minimum standard for staffing. And you can see the same thing. So what's going on here? I mean, 3.5, we'll talk a little bit more about this in the next couple of minutes. I mean, that is a New York State minimum standard. It was passed into law in the face of the atrocities, frankly, that happened to nursing home residents during the COVID pandemic. And to our knowledge, there has been no enforcement of that standard. And here you can see 2 years or so later, after that standard was implemented, and it is so low, it's well below the 4.1 needed, 3.5, you can see how many facilities are not meeting that standard. George Latimer's district, for instance, half the facilities are not meeting 3.5. What is going on for those residents in those facilities that are so way below 4.1? And what is going on with accountability for that care? Those nursing homes are being paid a lot of money. Most of the nursing homes in our area are operating as for-profit entities. And meanwhile, the understaffing is striking. I also wanted to show the same things, and I'll go quickly on a county level so you can see. This will be posted on the website. We'll try to do that today. But again, everything, including this presentation, will be on the website by Monday. But this shows you by the counties in our area meeting the nurse staffing standard of 4.1, or not meeting them or meeting them. And then this is looking at 3.5. This again is the state legal minimum and how many facilities are below that. Another way of showing that here, which I thought was just incredibly striking, and thanks again to John Rodat for sharing this with us. So this is all of New York State. Are New York State nursing homes meeting the state minimum standard? This is just the 3.5 hours. It's so modest. It's frightening to think about a facility having 3.5 hours, frankly, no matter less. But here you can see the blue is meeting they meet 3.5 hours or exceed it. And the orange is they don't meet 3.5 hours, excuse me, or they're at 3.5 or they're below. And these are the number of residents in New York State nursing homes in those facilities. And you can see it's almost equal. There are 49,482 residents in New York State nursing homes, probably today. This data is a little bit old, but it doesn't change that much, who are in facilities that are flouting longstanding state law, 2-year-old state law, I should say, just to be specific. That is really horrifying. And then 49,901 that were in facilities that at least had 3.5. What is going on? Why are we allowing half of our nursing home residents to be in facilities that are openly flouting the state's low minimum standard? It's to me beyond outrageous. And so this is for the Hudson Valley, and it's even worse in the Hudson Valley. Here you can see the majority, the top orange line, of residents in Hudson Valley nursing homes are in facilities that do not even meet 3.5 hours of care time. And that, I don't know if you can see the numbers at the top, but essentially it's 5,190 nursing home residents in our area are in facilities that at least provide 3.5. And that's nothing to write home about. I would be very frightened to send someone I love to a nursing home that was providing 3.5 or 3.6 or 3.8 hours per resident day of staff time. And close to 7,000 residents in our area, 6,932 to be precise, are in facilities that are not even providing 3.5 hours. It's 2 years after, in the face of COVID-19, the legislature passed and the governor signed this into law, and this is still happening. It's just so outrageous. This is just quickly a map showing where they are. As you can see, once you get up to Mid-Dutchess, Ulster County, this is for our area, there are all the facilities do not meet the 3.5 hours. Wow. And then below that, you can see there's a mix. Western Orange County, Northwestern Orange County, all orange. Beyond that, in Orange County, there's some more blue. And you can see in the Rockland, Westchester area that it's a mix. But really, really very frightening, and I think very damning about what is going on. The nursing home industry just got, I think it's $160 million increase in their rates for this year. Where is all this money going? Because as we see, it's not going to workers and it's not going to resident care far too often. And this is a graphic showing the names of those nursing homes. But again, you can easily go back and sort, with the data that I showed you earlier, what those nursing homes are that are 3.5 or below. And again, any questions, anyone wants some additional help, happy to either do a separate program or help in any way that we are able to. Okay, so moving forward, I know I went over with the data, so I'm going to try to move a little more quickly with the transfer and discharge. And I should say, starting off, is that we have 3 new fact sheets on transfer discharge because, one, it's a serious issue. 2, a lot has changed in the past month or so with transfer and discharge rights and protections. So we used to have 2 fact sheets. Now we have 3. And the two of them are split up just for the general public and on different aspects of transfer and discharge rights. And the third one is specifically for ombudsmen. So one reason why I started off by saying all that is because please don't feel like you need to take notes or anything else. Again, this program and the PowerPoint slides themselves will be on our website, and the materials, the fact sheets that I'm going to talk about are already there, free to use and share and download. So just very quickly, the nursing home reform law, the 1987 federal law, provides for all of these standards that we talk about, including protections against transfer and discharge. Why are we concerned about it? Just again, very quickly, and we see this a lot, especially in New York and especially in the areas, I would say, Hudson Valley has always been kind of an issue because the area around New York City and the New York metropolitan area, is expensive. It includes obviously a lot of people as a high density. So there are more opportunities in short for nursing homes to be figuring out how they can make money in as I would guess as sophisticated a way as possible. And by that I mean it's not just taking in residents and figuring out what the costs are and then making money. It's figuring out, for instance, with the transfer and discharge issue, is that quite often residents are transferred out or they're discharged because they came in for Medicare short-term rehab, which can pay upwards of $1,000 a day, and then their Medicare runs out and they need long-term care for many of these residents. So they need to stay on for some period of time. And Medicaid starts paying, and Medicaid pays on average, let's say roughly around 250. So $250 a day is a good amount of money, and nursing homes are making money off of that. However, of course, it's not $800 or $1,000 a day. That's big money. So what we see, and again, especially in areas around, such as the Hudson Valley, around New York City and the metropolitan area, is facilities, unfortunately, too often dumping residents because they have the ability to fill a bed with a Medicare resident, and they therefore flout some of the protections that we are going to be talking about. So these are the only reasons for which, under longstanding federal rules, a resident can be transferred or discharged from a facility. One, if it's necessary for the resident's welfare and their needs cannot be met in the facility. B, two, if the resident's health has improved so they no longer need a nursing home services. C, the safety of the individuals in the facility is endangered due to the clinical or behavioral status of the resident. D, the health of others in the facility would be otherwise endangered. E, the resident has failed to pay after reasonable notice. Or F, if the facility ceases to operate. And I should say, in regard to E, it doesn't mean just that the resident has failed to pay point blank the facility. It's really pay or make arrangements to pay. So if a resident comes in and they are eligible for Medicaid, but they refuse to cooperate, they refuse to either pay out of pocket, and they also refuse to apply, to cooperate with the application for Medicaid, then they could be kicked out. Doesn't mean the resident has to pay. It doesn't mean the facility can say, all right, Medicare was giving us $800 a day. Medicaid is going to give us $250. You need to make up the difference. If you don't do that, you failed to pay and go out. I hope that makes sense. It means that they have failed to either pay themselves or help to make arrangements, help to cooperate in applications for Medicare, Medicaid, other insurance, etc. This is really important. This is an additional New York State protection. Not many other states have this, and this is something we come across all the time. Again, it's the big issue of residents being dumped in New York State, but that is illegal. And why is it illegal? And this comes from, as I note below, from the New York Code of Regulations, and I cite it here. I include a link to it here, and I'll state it out loud. With regard to the assurance of equal access to care, the facility shall establish and maintain identical policies and practices regarding transfer, discharge, and the provision of all required services for all individuals, regardless of source of payment. There's a couple of exceptions. There are a couple of private facilities and or exempt facilities in New York. But otherwise, if you are participating in Medicare and Medicaid, as you can see from the charts I showed earlier, from those Excel tables, you can see whether they're participating in Medicare and Medicaid. Every single bed in a New York State nursing home is duly certified for both Medicare and Medicaid, meaning that there is not supposed to be a special Medicaid unit or a special Medicare unit. Every single bed is certified. There is no legitimate reason for saying to someone, we're out of long-term beds, or that we are no longer going to be a long-term facility. That is illegal. Uh, and I know from talking to ombudsman for many years throughout my career. I know from talking with families and residents throughout my career that too often this law is flouted, which is why we featured it here. It is really important. It's something special about New York. It's one of the few ways in New York in which New York provides additional protections in the federal rules. So please, again, this will be on our website. You're free to use it. You're free to cite to it, of course. And I think it's critically important because we're seeing so many nursing homes flout those rules. So I want to spend, say, another 10 minutes because I want to leave some time for Q&A, maybe another 5 minutes. So I'll go fairly quickly. And again, all this is on our, this will be on our website, but also this is all really coming from the 3 fact sheets that we have. So I'm just going to highlight a few things, excuse me. So there are important documentation requirements. As I know here at the top, a nursing home can't just cite one of these reasons. They can't just say that, oh, we can no longer meet your needs, so we're going to have to transfer you out of the facility, and that's the end of story. They have to document in the resident's medical record with the appropriate information and make sure that that is communicated to the receiving healthcare institution or provider. So if they're sending you to an adult home, if they're sending an individual to another nursing home, has to have all this information. And that must include the reason for the transfer, what the needs are. This is, to me, really important. This was a change that was made about 8 years ago in the federal rules. When a resident is being transferred because the facility says it cannot meet the needs of the residents, it has to specify in the medical record what those needs are that can't be met, how the facility attempted to meet those needs, and the special services that are available at the receiving facility that will help the resident meet those needs. There may be legitimate reasons to transfer a resident under these circumstances. It may be that they have become, ventilator dependent, and the facility in which they're living doesn't have the capacity to do that, and there are facilities that do. But those are, what we're trying to do here, what the federal government is trying to do here is make sure that that's the exception, because facilities, when they admit someone, they are saying that they can provide care for them. Facilities are licensed to provide a range of care and services for obviously a very vulnerable population. So this should really be the exception. And importantly, lastly, as I note here, is that documentation must be made by the resident's physician for reasons A and B, and by a physician, but for reasons C and D above. And I'll just go back there quickly. And I'm taking more time than I wanted, but I wanted people to see. So for A and B here, it has to be documented by the resident's own physician. And for reasons C and D, it could be by any physician, but it has to be by a physician. It's not an LPN, it's not a nurse aide, it's not a social worker. These all require A, B, C, and D that a doctor has signed off. It's someone who has their medical practice, their license on the line. Facility has to provide appropriate orientation in a way that the resident and the individual can understand, the facility has to provide notice of bed hold policy. I'm going to skip over that quickly. Bed hold policy means if a resident goes out, say, is hospitalized, what the policy is for holding the resident's bed for them to come back, and that generally comes from the state. And then there are significant appeal rights for transfer or discharge. And while the appeal is pending, the facility cannot transfer the resident out. I'm just going to make that very quick note, unless, as I know here in the exception, if staying in the facility would endanger the health or safety of the resident, him or herself, or of other residents in the facility. And again, I'm sorry, I want to go a little bit more quickly, so I'm being a little bit choppy here. Transfer and discharge notice. Importantly, and this is why I said there's been some recent changes, is that CMS, the federal agency, changed the guidance for how this is done a couple of months ago, and that guidance went into effect at the end of April. And part of that was that the facility now has to send a copy of the notice at the same time it gives it to the resident or their representative, which is at least 30 days in advance of the transfer to the ombudsman program. So the ombudsman program, under the new federal requirements, has to receive the notice 30 days in advance. And that is really important. Again, the standard was, this protocol was announced last year, but it went into effect on April 28th. So it is new in that sense. It's only about a month old, but facilities have been aware of this for quite some time now, and there's no excuse. I'm not going to get into this. These are the required contents of the notice. Again, this is part of our fact sheets, and these are the fact sheets themselves. So this is fact sheet 1, and it's available on our website in our fact sheet center. This goes to the essential protections, those transfer and discharge protections that I just mentioned earlier, and documentation, and the right to repeal. The second transfer and discharge fact sheet goes to the right to return to the facility, which of course goes with notice requirements for bed hold and for the transfer and discharge of the resident. So we tried to kind of put them together in a way, the two different fact sheets, in a way that was useful. All of our fact sheets, except for 1 or 2, are only 2 pages long. You're free to use them, to share them, to distribute them to your constituents, to share them with the nursing homes themselves, to share them with residents and families. We strongly encourage doing that. And then lastly, this is our special fact sheet for long-term care ombudsman, and it talks about, the notice that must be given to ombudsman. It talks about, discharge planning. And I also provide here on the right-hand side some investigative procedures for the state surveyors. And why do we include that? So these are investigative procedures, what the federal government expects the state inspectors, the state surveyors, to be doing. And so that's important because it lets us know how the nursing homes are to be held accountable and how the state surveyors are supposed to be in touch with and connecting with the long-term care ombudsman. So all this information we actually have, in addition to our fact sheet page and it being on there, we have a special page dedicated to inappropriate transfer and discharge materials. Here you can see it includes the 3 fact sheets. It includes the federal guidance itself. So we just synopsize the federal guidance, but if you're interested, if you have questions, if you're getting pushback, we actually, we have the federal guidance, the language itself, and some other resources and materials here. Those are all on our website, nursinghome411.org/discharges. And that's it. We'll leave some time, I think, for Q&A. Good. Our next program is on August 14th at 11 a.m. We're doing these programs for the Hudson Valley every other month. We'll do another data update, and then residents' rights. We're actually going to have a special guest speaker, Deb Truhowski. She is an attorney. She's just a wonderful and thoughtful person, and she's going to be talking about abuse and neglect and what to do when they are suspected. And then here are some places to go for more information, to join us. Email us at info@ltccc.org if you'd like to suggest a topic, or if you have any questions, or again, if you want more help or whatever, we'll do our best to help you out. And then we're on the web, Facebook, Twitter, Instagram, etc. And lastly, a special thanks to the Dyson Foundation and to the Fields Hall Foundation for supporting these programs. And then if anyone has any questions, feel free to unmute yourself. I think we could do that.
Yes, they should be able to do that. It doesn't look like
Great.
we have any questions in the chat, but if anyone has any questions they'd like to ask live, just come off mute. And thanks so much, Richard. This was excellent.
Oh, good. Thanks.
Richard, I
Hey,
just
Kelly.
want to say that this was a great presentation. I really did appreciate the data in the beginning, and I was trying to keep up like trying to master it in
A lot,
nursing home
yeah.
411 and appreciated Haley you sending those links. So I'm going to save them and, you know, definitely on Monday when the links come out and the presentation comes out, I want to share it because, you know, we do work with those facilities and seeing the staffing shortage and how it can impact really, it does make it a difference and it can kind of paint a different picture from the ombudsman lens as well.
Thanks so much. I really appreciate you saying that. Thank you. Any other questions or comments? And again, feel free to email us. It doesn't have to be right now. But we want to make this as useful as possible and support, you know, everything you all are doing and your systemic advocacy when you talk to legislators, et cetera, that you're well supported in the work you're doing as families, as ombudsmen, as agency people, et cetera. Okay. Well, thank you. Thanks so much for joining us on, I understand, a hot day in New York. And have a good afternoon.
Thank you.
Thanks. Bye.